management of pain. We have Dr. Sunil Kumar from Pallium, India. He is the additional director for the Trivandrum Institute of Palliative Sciences, and which is also a WHO collaborating center for training and policy making. Dr. Sunil Kumar has an extensive experience and accreditation for working and being in palliative care. He has obtained his bachelor's and master's degree from Cardiff University, and he has a rich 15-year experience managing patients in palliative care. And he is also the lead for clinical services, academics, and research of Pallium India. A warm welcome to Dr. Sunil Kumar, and I hand over the session to you to take us through.
Thank you, Madam. Good afternoon, everybody. So I will share my PowerPoint presentation. And I would request all of you to be interactive. Okay. We are planning to cover opioids for moderate to severe pain. And yeah, this is what we are going to discuss today mainly, but there would be, we will have one or two cases traced on step 2 of WHO analgesic ladder 2. So we'll be discussing what are the opioids available in India, because we know that there are many opioids available in country, but what is it that available in India which we can use, and how the opioids are acting in our body. Then most importantly, when we practice, we will have a lot of doubts. So we'll be talking about that. Then another important aspect is adverse effects of opioids, which we should know very thoroughly. And the last one, but not the least, it is you should understand the prices of different opioids, because it is going to affect the patient. If you prescribe some medication which is costly for a poor patient, we are prescribing buprenorphine patch for a patient who is unable to find out his food, then probably he will come after 2 weeks and will tell you, I do not have pain relief. So you may increase the dose of buprenorphine patch without knowing that he is not using it. So that is also very, very important. So all of you know that this is the WHO analgesic ladder, and the opioids, it comes in the second stage, but that is the opioids for mild to moderate pain, or some people call it as weak opioids, but better term would be opioids for mild to moderate pain. And in the third step, we have opioids for moderate to severe pain. So what are the opioids available to treat mild to moderate pain in India? Can somebody tell me? Please unmute and speak.
Codeine, tramadol.
Yeah, codeine, tramadol.
Tapentadol.
Yeah, tapentadol. Okay, very good. So tramadol, tapentadol. Okay, tramadol, tapentadol, dextropropoxyphene. I don't know any of you know about this medication, but this was a medication which was used by during 2000, maybe 2010 up to 2015, I think. So this was available as Proxy-1, which contains dextropropoxyphene and paracetamol. But then the use was suspended in 2016 or 17, something like that. But now it has come back into the market. And codeine also. So these are the opioids for treating mild to moderate pain, which is available in India. What are the opioids for moderate to severe pain?
Fentanyl, morphine,
Yeah, fentanyl, morphine. What else? Anybody please help?
Buprenorphine.
Buprenorphine. Yeah, but I would not put it under opioids for moderate to severe pain, though it is available.
methadone.
Yeah, it's methadone. So we have morphine, fentanyl, and methadone. Okay, these are the opioids which used to treat severe pain worldwide. And we also know that there are some opioids like buprenorphine, pentazocine, which is also available. But this is not commonly used. So I have not put it under the two groups. So the role of buprenorphine and pentazocine is very, very restricted. So just want to tell you a patient story. You can see a patient here. What is his problem? Can anybody try? What is he suffering from now?
Pain may be due to CA cancer of jaw.
Okay, very good. Yeah, jaw pain. I can see there are some chat responses also. Jaw pain, trigeminal neuralgia, toothache. Yeah. So how severe his pain is from his facial expression? It's very severe, isn't it? And after an hour or so, he is smiling at us. So how is it possible to make such a difference in this short time? What would you do in your practice? So I will give you a short history of this patient and then you can tell me. So this is a 56-year-old man who is suffering from carcinoma of the larynx. So his main complaint is pain around neck, which he scores 10 by 10. That is worst imaginable pain. And he described it as a sharp pain without any radiation. And this was there for the last 2 weeks. And because of this, he is unable to sleep. So what would you do for this patient? I know many of you are.
Patient started with the patient having moderate to severe pain, so we'll started with fentanyl or morphine to this patient. And
Okay.
after managing this patient, we will take this patient to the surgical management because it's a CA larynx. So there is a problem with the phonation in this patient. So we want to correct that patient. So medical plus surgical management.
Yeah, I just want to tell you that this patient already underwent surgery and not surgery. Yeah, he underwent tracheostomy, radiotherapy, and chemotherapy. So this is a picture after 2 years of history. So right now his main problem or his complaint is the severe pain, making him unable to sleep.
We'll
So,
start the patient with the oral oral tablets like morphine. We'll start with morphine.
okay.
If it's a severe pain, we'll start with the patch, fentanyl patch for this patient.
Okay. Thank you.
IV morphine would be preferable under monitoring since the patient is in severe pain.
Okay, thank you, Dr. Aditi. So I just want to ask you, suppose we have very severe pain, how fast would we want pain relief?
Immediate.
Immediate. So So for this patient, what would you want to do? Can we give some IV opioids so that he will get faster pain relief?
We
Yes,
started with
IV
IV for
morphine.
this patient.
Yeah. So, so this is known as usually it is a morphine. Most of the palliative care unit have access only to even many of the palliative care units does not have access to oral morphine. And very small number of palliative care units will have access to injection morphine. And injection fentanyl, most of the palliative care units or very rare palliative care units might be using. So usually the gold standard or the one opioid which is used to titrate for severe pain is intravenous morphine. So how do you do an intravenous morphine titration? So you have to give injection morphine 1.5 milligram at 10 minutes interval. So the ampule available to us is 1 ml, which contains 15 milligram of morphine. So we would dilute 1 ml of morphine with 9 ml of normal saline. So total it will become 10 ml, which contains 15 milligram. So each 1 ml contains 1.5 milligram. So this 1.5 milligram is given at 10 minutes interval. So do you expect any side effect, immediate side effect by giving injection morphine?
Sir, at 1.5 mg dose, patient is unlikely to have sedation, but still we
Yeah.
will keep monitoring. Sedation and drowsiness will happen only when after there is pain relief.
Okay. What other side effect are you expecting immediately?
Drowsiness,
Nausea.
respiratory depression.
Sorry.
Drowsiness, respiratory depression. Obstruction might not happen because the patient already has a tracheostomy in situ. So obstruction will not happen, but yes, drowsiness and respiratory depression will happen.
Drowsiness and respiratory depression. Anybody else?
Is there decreased peristaltis, movement and constipation?
Yes, those all are correct. But I am asking, by giving injection morphine, at the moment, are you expecting any side effects? Some of you
Nausea,
talked about,
vomiting.
yeah, that is nausea and vomiting. So if you are giving opioids for the first time, maybe 33%, that is at least 1/3 of the patients can have nausea and vomiting. So you have to give an antiemetic to prevent nausea and vomiting. So you have to give injection metoclopramide 10 milligram IV first, then followed by injection morphine 1.5 milligram at 10 minutes interval. And how long would you continue to give it? Or in other words, what is the end point of morphine titration? So it is either satisfactory pain relief or drowsiness, whichever be the first. So what you have to understand is that all the pains are not sensitive to opioids. In such patients, the pain relief would not be satisfactory, but the patient would be drowsy. So in such patients, you have to stop morphine trial when the patient becomes drowsy. But if the pain is opioid sensitive, then they will have a theoretically full pain relief. So when you do a intravenous morphine trial, you can make a chart like this, in which you can chart out time with pulse rate, respiratory rate, blood pressure, what is the pain score, is the patient drowsy or not, what is the dose of injection morphine you have given. So you can see this patient has come to us, suppose at 10 a.m. So you will record all the vitals. You recorded the pain score. You see that patient is not drowsy. Then you will give injection morphine 1.5 milligram. Then wait for 10 minutes. At 10:10, you will again assess the patient and you will record all the vitals. You will ask the patient, what is the pain score now? So he says it is 7. Is the patient drowsy? No. Then you can give another 1.5. So you can see by 10:30, this patient pain score is 1 and he is not drowsy. So this is an indication to stop IV morphine trial because he has satisfactory pain relief without drowsiness. So how much intravenous morphine was needed to get pain relief? It is 4.5. Okay. So this patient who has a carcinoma of the larynx has pain for the last 2 weeks, and now he has relief with 4.5 milligram of intravenous morphine. So how would you, this patient wants to go home now. What would you do now?
So prescribe immediate relief morphine,
Yeah.
calculate total dose for the day, and then shift to sustained release morphine.
Okay, thank you. So what would be the dose you will start in this patient?
5 milligrams immediate relief in the beginning, QID, and the patient should be asked to stop, not take the next dose if he is feeling drowsy.
Okay, thank you. Anybody else?
Started with a dose of 2.5 milligram of BD. If the patient, the pain is relief, we can continue with that. If the patient complains of severe pain, we can increase the dose with the BD, TID, and QID.
Okay, I can see Dr. Bhargav Dev Chaudhary says 2.5 milligram of morphine 4 hourly. Okay, let's see. So how can we convert this into oral dose? So so this is a study done by Dr. Rajagopal, who is our emeritus chairman in 2000 in patients who presented to the palliative care unit with moderate to severe pain. And so this is the basis of intravenous morphine trial that we use in India. And according to this study, they say that approximate 1:1 ratio of intravenous to oral dose is a good starting point. That means this patient received 4.5 milligram of IV morphine. So you can directly convert it into the same dose of oral morphine. That is what is meant by 1:1 ratio. So 4.5 milligram means 4.5 milligram of oral morphine. But we also know that it would not be possible for us to give 4.5 milligram of oral morphine. So the next possible dose would be 5 milligram. Most of the palliative care units would have 10 milligram tablets, that is immediate release. So you can give 10 milligram half, that means 5 milligram. And you also have to understand that the duration of action of morphine is 3 to 5 hours. Usually it is given 4 hours. So morphine has to be given every 4 hours. So this is how we can give this for this patient. Tab morphine 10 milligram half instead of patient when patient wakes up say at 6 a.m. So the next dose would be 10 a.m. and every 4 hourly you have to give, but you note that at bedtime or 10 p.m. the patient usually it is the double dose of morphine is given at night. Okay, so instead of 5 milligram at 10 p.m. You give 10 milligram so that you can avoid that 2 a.m. dose. Okay. And so even though we say it is morphine 10 milligram half Q4S, understand that 2 a.m. dose is not usually given, and at 10 p.m. double dose is given to avoid the 2 a.m. dose. And in addition, we can also give SOS doses. The SOS dose would be same as that of normal dose. That is here, it is 5 milligram. So the SOS dose would be 5 milligram. Suppose the patient is taking morphine 20 milligram every 4 hourly, the SOS dose would be 20 milligram. If he is taking 100 milligram every 4 hourly, SOS dose would be 100 milligram. Okay. So many of the palliative care units may not have injectable morphine. So it is also important to understand that we can use oral morphine in such patients. So if the patient is opioid naive, that means if the patient is not taking any opioids, including weak opioids, then we can start with 5 milligram of morphine every 4 hourly with SOS doses. But if they are taking peak opioids, then you can start with 10 milligram of morphine every 4 hourly with SOS dose. So for our patient, we started him on morphine 5 milligram every 4 hourly with SOS doses. And he is relatively pain-free for the last 2 weeks. But then he started taking more SOS doses, and it went up to 3 SOS doses. So what shall we do now? And how frequently we can give SOS dose of oral? 2 questions. Do we need to do anything with the dosage of morphine now? And how frequently we can give SOS dose of morphine?
Sir, we should start on sustained release morphine. Patient is taking 5 mg 4 hourly, so that means 30 mg is the daily requirement. So 15 mg morning, 15 mg evening sustained release, and plus in between, if he requires SOS dose, we can add on.
Okay. Anybody else?
Before tapering morphine, we should try tramadol, tablet tramadol.
And now this patient is already on morphine. So he, in addition to the regular dose, he is consuming more morphine. So we cannot taper down morphine here because his use of morphine is increasing.
Increase the morphine dose to 5 mg, 10 mg.
Okay. Okay, thank you. So what we have to do is that this patient is taking more SOS doses. That means the present dose is not sufficient. That's why he is taking more SOS doses to relieve pain. So you have to increase the dose, isn't it? So how do you increase the dose, or what is the indication to increase the dose of morphine? So if the patient is taking 2 or more than 2 SOS doses, then you can increase the dose of morphine by 30 to 50%. So this patient is taking 3 SOS doses. That means he is taking more than 2 SOS doses. So you have to increase the dose of morphine. How much? It is by 30 to 50%. So if you take, suppose you want to increase 30%, that means what would be the 30% of 5 milligram? It is 1.5 milligram. So total dose would be 6.5 milligram, which obviously would not be possible to give. So we would go for 50% increase. 50% of 5 is 2.5. So 5 plus 2.5, 7.5 milligram. So you can give 7.5 milligram every 4 hourly with the same 7.5 milligram as SOS dose. But many of the caregivers would tell you that it is very difficult to break the small morphine tablet into 4 pieces. I don't know how many of you have seen the morphine tablet, which is very small, and when you break it into 4 pieces, it would be very difficult. So even 10 milligram 4 hourly would be okay for this patient. So please understand that when the patient is taking more than 2 SOS doses, that's an indication to increase the dose of morphine. So how frequently we can give SOS dose of oral morphine?
Whenever the patient is in pain.
Okay, suppose you have given morphine at 6 a.m. Okay, so you have given morphine at 6 a.m. During that time, patient had severe pain, and you told her to wait. But after half an hour, the patient tell you that, doctor, I do not have pain relief. Please do something. So, would you give morphine or
2 hours, we can wait, we should wait for 2 hours.
we should wait for 2 hours? Okay.
Since it is an
I can
oral dose.
see that there are many responses in chat, but I would not be able to see those chats because I have to stop doing this and then to look at the chat. Sangeet, you have please
Yes, sir.
not-
Yes, sir. I
I
can
can
wait.
have a look and
yeah.
keep track.
Okay. So in order to understand how frequently we can give as a source of oral morphine, I think we need to understand a little bit of pharmacology of morphine. So this is the plant, poppy plant or opium plant, or scientifically it is Papaver somniferum. So this plant is legally grown only in 4 states in India: UP, MP, Rajasthan, and Himachal Pradesh. And any of you have seen this plant? If you are from this states, I have not seen this. Any of you have seen? Yeah, I can see there is one response. Dr. Yash Javeri. Where are you from, Dr. Yash?
I am at Lucknow, boss. Sir.
Okay.
I am at
Yeah.
Lucknow.
Okay, thank you.
Thank you, sir. Thank
Yeah. So this is legally grown only in these 4 states. And you can see these are opium fields, like paddy fields in Kerala and many other states. These are opium fields. And opium is available from all the parts of the plant. But the most abundant, it is most abundant in the pod. So you can see the seed-like things, which is known as pod, POD pod. And the farmers, when it matures, you can see they are making small cuts on the board, and the sap would ooze out, which the farmers will collect and dry it in sunlight. And then this would be transported to government opium and alkaloid factories in Nemuch. And these factories will make morphine powder out of it. And then this will be transported to various pharmaceutical across India. And these pharmaceutical companies will make morphine powder injection from this powder. So that's how we get morphine tablet. For those who are from Kerala, morphine is, we can get morphine from Lisi Hospital Pharmaceuticals in Kochi. And other place would be Regional Cancer Center Trivandrum, but they would give it to only to their patients. But all the palliative care units in Kerala gets purchase morphine from Lisi Hospital Pharmaceuticals. Okay. So regarding the pharmacokinetics, how morphine is absorbed. So once you morphine is it is bitter. So if you powder the tablet, then you have to sweeten it with the sugar or fruit juice. Otherwise, the patient would complain about it. So it is bitter. And another thing is that it is water soluble. So you can, if needed, that can be dissolved in water and can be administered. And once it is morphine is swallowed, it is absorbed from the upper small bowel. And another thing is that even though there are various routes of administration, sublingual, buccal, and gingival routes are not usually recommended for administration of morphine, because we don't know how long it is going to take to absorb from these roots, and the absorption is, as such, is very low. So it is not recommended to give morphine sublingually, buccally, or gingivially. So what happens after you take morphine orally? It goes into the GI tract, then it will be absorbed into the blood vessels of intestine, and from there to portal vein, and then to liver, where the metabolism takes place, and then metabolites are liberated into the systemic circulation. So the main site of metabolism of morphine is liver, but there are minor sites of metabolism like kidney and GI tract, but mainly it is metabolized in liver by glucuronidation. So morphine is metabolized by glucuronidation, and you can see it is converted mainly into two metabolites. One is morphine 3 glucuronide and the other one is morphine 6 glucuronide. In short, it is called as M6G and M3G. Both of the components are not analgesics, but M6G is the metabolite which will give you pain relief. But please also note that that is the component which is formed less in quantity compared to M3G. So M6G is formed in less quantity and it is more potent than parent morphine. And M3G doesn't have much action, but there are literature which says it may contribute to neurotoxicities of morphine. Okay. So now we can try to answer this question. How frequently would you give SOS dose of morphine? So we have to understand that this morphine is gradually absorbed from the GI tract and then goes into the blood vessels of the intestine, then to portal vein and in liver where it is metabolized, and then it is the metabolites are liberated into the systemic circulation. So it says that the pain relief would start by about 30 minutes, but the peak would be by about 1 hour. So it is usually advisable to give SOS doses after 1 hour of the previous dose of morphine. So wait for 1 hour and then administer the next dose. Okay. So our patient, because of his pain, we increase the dose of morphine to 10 milligram every 4 hours. But patient says it is very difficult to take it every 4 hours. That's very correct, isn't it? Because if you think about yourself or ourselves, if we are prescribed with amoxicillin for 5 days, how many of us are going to complete this 5 days course tedious every day? And here this patient is going to take morphine for a long time, every 4 hours. So it is very obvious. Patient is asking, sorry doctor, I would not be able to take it every 4 hours. Are there any way you can give it less frequently? What would you do for this patient? Please unmute
15 milligram, 15 milligram 6 hourly.
15 milligram 6 hourly. Yeah. Any other responses?
Sustained release dose.
Sustained release also they have mentioned.
Okay.
Yeah. Okay. So sustained release is an option. So what are the properties of sustained release morphine compared to immediate release morphine? Sustained release morphine, its duration of action is 12 hours, whereas the duration of action of immediate release morphine is 4 hours. So what would be the dose of sustained release morphine for this patient?
BD.
Yeah, what is the dose?
15 mg or 15 mg every 12 hours.
15 mg. What is the total dose of morphine he is taking now
40 is.
per day?
60. 30 mg would be.
It is 60, isn't it? 10 milligram into 6. That is 60 milligram. So you have to divide it into 2. That means 30 milligram. 30 milligram BD. Okay. So one of the common mistake that is usually seen is 10 milligram 4 hourly. People will calculate it is 10 into 4. That is 40 milligram. And that is not right. 10 into 6. That's the number of doses we are administering. So total 60 milligram. So 30 milligram PD. But suppose this patient is having breakthrough pain. What would you do then?
Now prescribe immediate release morphine.
How much? What would be the dose of immediate release morphine for this patient?
10 mg.
10 mg.
Yeah, just calculate the total dose. It is 30 milligram plus 30 milligram. That is 60 and divided by 6. So that would be 10 milligram. So for breakthrough pain, you always use immediate release morphine. So 10 milligram would be the dose. So just want to show you the differences between oral, sub-Q and IV bolus doses, the effect. But please take it just as a guideline. These are not hard and fast. You will find some other value if you refer some other articles or books. So here you can see the oral immediate release tablet. The peak effect is by about 1 hour, whereas subcutaneously peak effect, they say it will take up to 50 to 90 minutes, whereas IV bolus dose, it will take 20 minutes. But the duration of action is 4 hours, except for sustained release morphine, where it is 12 hours. And you can see what happens with the immediate release morphine. So the graph in red that represents oral administration, because we give it every 4 hours. So the blood level of or plasma concentration of morphine, it varies. Sometimes it goes down, sometimes it goes up. But look at the green line, which is where the plasma concentration is kept more or less constant, so that the chance of side effects are less. So that's the advantage of sustained release morphine tablet. But we have to also understand that it is costly compared to immediate release morphine. It is almost maybe twice as costlier than immediate release morphine. So what are the preparations of morphine available in India? One is aqueous solution, that means syrup, but this is not available everywhere. It is specifically available in some centers only. Then we have tablets as well as capsules, both available as immediate release and controlled release form. Then injection. And I also understand that for some states, it would be 10 milligram per 1 hour. So we, our patient, he is still on 10 milligram of morphine every 4 hourly for the past 6 months. But then he was brought to the casualty one day with excessive drowsiness. And on investigation, you find that his total count is elevated. His serum creatinine is 5 milligrams per deciliter. And what are the reasons for this excessive drowsiness?
Inadequate excretion of morphine, thereby resulting in morphine toxicity.
Okay. Yeah. So, would you do anything with the morphine dosage then?
Dose reduction is needed.
Okay, dose reduction is needed.
So morphine metabolite cause the renal toxicity.
Okay. Morphine and its metabolites will not cause a toxicity, but the accumulation of morphine and its metabolite causes toxicity. I just want to make it clear that NSAIDs can cause injury or it can even cause acute kidney injury, but morphine will not cause any kidney injury, but rather its metabolites accumulates, and that's why you have extreme drowsiness. Okay, so here comes how morphine is excreted from our body. So it is by glomerular filtration. So if there is anything that is going to affect kidney, like CKD, chronic kidney disease, then whatever you give the morphine and its metabolite, that will accumulate in the system, and the clearance is reduced, so that half-life of morphine is prolonged. So what happens is, whatever you are giving would be there in the blood. It is not excreted from the body. So that's why you have extreme drowsiness. So, so in renal failure, we have to understand that we have to use the morphine in a reduced dose, as well as instead of 4 hourly. Here is the situation where you will administer morphine maybe every 12 hourly or 8 hourly or 6 hourly, depending on the serum creatinine and response of the patient. Or else you can use the opioids which are renally safe. So which are the opioids which are supposed to be renally safe?
Fentanyl.
Okay.
Tramadol.
Okay. Anything else?
Tapentadol.
Okay. Anything else? Okay. Fentanyl, methadone, and tramadol. Okay. But you have to understand that in end-stage renal disease, that is when the CKD stage 5 patients, the dose of tramadol would be 100 milligram maximum per day. So fentanyl and methadone are the 2 strong opioids which can be used safely in CKD patients. So, okay, now our patient, because of renal failure and his serum creatinine is elevated, we reduce the dose from 10 milligram every 4 hourly. We reduce it to 5 milligram every 8 hourly. And he was very much okay. But after 2 months, he was unable to swallow anything, including morphine, probably because the patient is near end of life and this patient is at home. And if he do not take the morphine, he has severe pain. So what would you do for this patient?
IV morphine.
IV morphine? Yeah. Yeah, that's an option. What else?
Buprenorphine
People
patch.
have a message fentanyl patch also, Dr. Sunil.
Buprenorphine patch, fentanyl patch. Okay. Any other way? Sorry?
NG tube.
NG tube. Yeah, but we have to understand that we are talking about a patient who is near end of life. So we should do minimum interventions at that stage, because anything we do, it should not do any harm to the patient. Okay. So I would not use fentanyl patch or buprenorphine patch in this patient because of
Yes,
many other reasons. One is cost, and the other one is we will come to that later. But can we use morphine itself? Injection morphine, yeah, IV morphine can be used, but uh, uh, whether your hospital would allow the patient to take injection morphine to their home, that's a big question. I think it may not be possible for you, but we do give injection morphine to the patients after breaking the ampule and loading it in the syringes. We send it to patient home. But this may not be possible with many of the hospitals because of hospital policy and things like that.
Sir, we can dissolve the morphine tablet, crush
Ah.
it, dissolve it, and with some
Ah.
fruit juice or something.
Yeah, that's a good thing, but even unable to take water, so that's the problem. Okay,
so anything,
so we need to understand what are the routes through which you can administer morphine.
can we use rectally?
Okay, so we can use morphine, give morphine orally, and this is the most common route, followed by intravenous or subcutaneous administration. And we can also administer morphine correctly. Okay. Then epidural and intrathecal. So in this patient, which route would you select?
Correct.
Yeah, rectal. So I
Yeah,
told
per
you that morphine is water soluble. So you can take the morphine, 5 milligram. He was getting 5 milligram 8 hourly, isn't it? So take 5 milligram of morphine. Add 1 or 2 drops of water, make it a paste, do a rectal examination, and deposit on the rectal mucosa. So the effect of rectal morphine is same as that of oral morphine. Whatever you administer orally, the effect will be same when you administer rectal. So 5 milligram 8 hourly orally means you need to administer 5 milligram 8 hourly rectally also. Okay. So for this patient who is approaching end of life, you can use rectal morphine. Okay, now we are coming to another patient. So it's a 55-year-old lady with carcinoma of the colon who complains of abdominal pain, which is continuous in nature, but she's on 10 milligram of morphine 4 hourly, and she has good pain relief, and she is not taking any SS doses. The pain is controlled with 10 milligram of morphine every 4 hourly. And this is another patient who asked the doctor to reduce the dose, or if there is any other medication which can be taken less than 4 hourly, I would like to take it. Then this doctor converted this morphine into fentanyl patch, and he advised 25 microgram of fentanyl patch. But the patient comes to you next day, and she's telling you that they changed the fentanyl patch after 5 hours, as she had no pain relief. They removed it. The fentanyl patch was removed after 5 hours, as she had no pain relief. So what would you do now? Sorry, Dr. Piyush, unable to hear you. Oh, it's very
Still, your
feeble.
voice is not clear, very feeble. Maybe close to the mic, you may have to speak.
Anybody else? What would you do for this patient?
The fentanyl patch require around 10 to 12 hours required and for the action for this fentanyl patch because it is a slow releasing one. So for that time, we should supplement the patient with other drugs. For this patient, we can continue the patient for morphine for that time and counsel the patient that only after 10 to 20 hours, the fentanyl patch should work and don't remove the fentanyl patch before that.
Okay, very good, Dr. Anju. So we have to understand some facts about fentanyl patch because nowadays everybody is using fentanyl patch, which is not a good practice. So you can see this is the fentanyl patch, and the protective layer would be removed. Protective liner would be removed before you keep it in the skin, and from this is the reservoir from which drug is constantly diffused into the subcutaneous tissue. And subcutaneous tissue is a site where there are lots of blood capillaries are present. So what happens is before the fentanyl patch acts, it first forms a subcutaneous tissue depot. Okay, give me 1 minute. So, what happens is fentanyl is slowly liberated into the subcutaneous tissue and it forms a subcutaneous tissue depot or subcutaneous tissue storage. And from this storage, fentanyl is gradually liberated into the bloodstream. So, for this subcutaneous tissue depot or storage to occur, it will take about 8 to 12 hours. So, for the first 8 to 12 hours, for a patient for whom you apply the fentanyl patch, there will not be pain relief. So, you have to actually educate the patient about this. Otherwise, like this patient who removed the fentanyl patch after 5 hours, that would happen. These all are real stories because many patients come to us and this is one of such stories. So this is most important thing that you have to understand. And another thing is that the duration of action for fentanyl patch, it lasts for about for 3 days. But in some patients, it lasts only for 2 days. That can also happen. And when you apply the fentanyl patch, there would be hair in many areas, but you should not advise the patient to shave the area because shaving will produce aberrations and this can increase the absorption of fentanyl. So you should not shave the area, rather you can cut the hair. And another thing is that temperature will also affect the absorption. So if patient is having fever, or you should ask the patient not to take hot bath, or they should avoid going to stove or kitchen and avoid cooking. Otherwise, it will increase the absorption. And another most important thing is that the fentanyl patch is not suitable for patients with unstable pain or patients who has acute severe pain, because you know that if you apply a fentanyl patch, suppose it is 25 microgram patch, that means 25 microgram of fentanyl will be liberated every hourly. That's what 25 microgram fentanyl patch means. You would not be able to alter the dose of fentanyl. Okay. So if a patient has acute severe pain, we would not know how much opioid this patient requires. Does he require 12.5 microgram patch, or is it 25 microgram patch or 50 microgram patch? We don't know. So it is not a good practice to give fentanyl patch to a patient who has acute severe pain, and also for a patient who has unstable pain. So what is unstable pain? Suppose a patient whose pain is going suddenly going up. To find out what is the dose of opioid required for that patient by short-acting opioids like immediate release morphine. And once you find out the stable dose, then you can convert it into fentanyl patch if required. But you understand that fentanyl is 100 times more costlier than morphine. And these are the available. You have injections, transdermal fentanyl patch, and oral transmucosal fentanyl citrate. This is like a lollipop, which you can rub over the oral mucosa, and you will get instantaneous pain relief. This would be good for patients who has incident pain, that is pain during movement. Suppose the patient went to bathroom and he has severe pain. You can just rub it over the oral mucosa and the patient will get immediate pain relief. But as of now, this OTFC is not available in India. Compared to morphine, this is more of lipophilic, whereas morphine is hydrophilic, water soluble. And this is 100 times more potent than morphine. So it is always expressed in terms of micrograms. And if you calculate like that, 60 milligram of oral morphine equivalent per day would be equivalent to 25 microgram per hour fentanyl patch. So just remember this, only this 60 milligram of oral morphine equivalent would be equal to 25 microgram fentanyl patch. So 120 milligram of morphine would be equivalent to 50 milligram of fentanyl patch. So this is for easier calculation. So now we are moving on to another patient. Mr. P, a 70-year-old man who has carcinoma of the lung, is complaining of throbbing pain on right front of chest, which is continuous in nature, and the pain score is 5/10. He is a non-epileptic and he is on levetiracetam 500 milligram BD. How do you manage his pain? So this patient's pain is 5/10. That means he has moderate pain. So which step of WHO analgesic ladder are you going to use?
Weak opiates.
Yeah. So which one? So what would you use for this patient?
Tramadol.
Okay. Tramadol. Yeah. Anybody else has any opinion?
Not using tramadol for this patient because tramadol can decrease the seizure threshold
Tramadol.
for the patient.
Okay. So regarding tramadol, a few points that you have to notice that it is less potent than morphine. Compared to morphine, it is 1/10 as potent as morphine. That means 50 milligram of tramadol would be equivalent to 5 milligram of morphine. 50 divided by 10. Okay. And it has a dual mechanism of action. That means it acts like opioids, other opioids. It acts on opioid receptors, on mu receptor as an opioid agonist. And it also acts like tricyclic antidepressant. That means it inhibits the reuptake of noradrenaline and serotonin, and it increases the concentration in the dorsal cone of spinal cord, and thereby it reduces the pain. So these are the two mechanisms of action of tramadol, and maximum dose recommended is 400 milligram per day. And for this patient, if it reduces the seizure threshold. So this patient is already a non-epileptic. So if you give tramadol for this patient, there is a chance that you may precipitate a seizure. So never go above the recommended dose. And when you give an intravenous tramadol, it should be given very slowly because it can precipitate seizure in some patients. And tapentadol is the newer generation of tramadol. But what you have to notice the potency. Tramadol, it is 1/10 as potent as morphine, but tapentadol is more potent compared to tramadol. It is 1/3 as potent as morphine. Otherwise, most of the things are same as that of tramadol. Okay. Now we are moving on to another patient, Mrs. P, who is on tap morphine 50 milligram every 4 hours. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. So how will you manage this patient who has very severe pain? But you have only injection pentazocine and oral morphine tablet. How do you manage? Any idea?
Injection pentazocine IV slowly diluted.
Okay, thank you, sir. Anybody else?
IM pentazocine with oral morphine.
Pentazocine, okay.
So any type of the injection, pentazocine injections, so before that the secure the oxygen levels very important. So go for the respiratory depressions that IM or IV.
Okay. Yeah. For this, to answer, we need to understand something else about.
Couple of responses have been telling that just increase morphine.
Okay.
Piyush and Dr.
Right.
Jyoti and Dr. Bhargav also all telling just increase the dose of oral morphine.
So why do you want to increase the dose of morphine? So to answer this, just understand this a few things. What is an opioid? For a medication to become opioid, it should have two properties. One is that the medicine should produce its action by combining with opioid receptors. And this action should be antagonized by naloxone. So these are the two properties for a medicine to call it as an opioid. Okay. So what are the receptors of opioid? Because opioids act on opioid receptors and produces the physiological effects, which includes pain relief, respiratory depression, constipation, nausea, vomiting, itching. There are many things which are the physiological effects. So mu, kappa, and delta, these are the three main opioid receptors present in our body. And this is present entirely in the nervous system, but is more concentrated in brain and spinal cord. And according to the action on receptor, the opioids are divided into three, into agonist, antagonist, and agonist. So what is an agonist opioid? Agonist opioid means it combines with opioid receptors to produce the physiological action. So if you give a tramadol, it will combine with opioid receptor, mu receptor, and then it will produce its physiological effect. That means it can produce pain, it can produce constipation, nausea, vomiting, itching, urinary retention, all those things. And if it goes into toxic doses, respiratory depression. What is an antagonist? Antagonist means it is an opioid which acts opposite to agonist. So antagonist works only in presence of an agonist. That means if suppose I am giving an antagonist, for example, naloxone, injection naloxone, I am giving to Dr. Anju. It will not have any effects in her body because she is not taking any opioids. So it works if she is taking morphine or tramadol, it will reverse the effect of that opioid. Okay, that's the action of antagonist. What is an agonist antagonist? So on certain receptors, this group acts as an agonist, whereas on certain receptors, it will act as an antagonist. So it will have a mixed action. That is what agonist and agonist means. And just look at this graph between agonist and agonist group. On the y-axis, it is pain relief, and on the x-axis, it is the dose of opioid that you are going to give. Suppose you are giving agonist opioid like morphine to a patient who has who says his pain score is 10/10. You can see when you give a small dose of morphine, it will give this much pain relief. And when you increase the dose, the pain relief would be increased. And when it reaches here, it will give complete pain relief. That means as the dose of opioid agonist is increased, there would be corresponding pain relief. But look at the other graph, agonist and agonist. What happens here? Initially, there would be corresponding pain relief when you increase the dose of agonist and agonist. But after a point, what happens? The curve plateaus. So that means even if you increase the dose, it is not going to give you further pain relief. So there is a maximum dose. That means this group of medication have a ceiling effect. So there is a ceiling effect for analgesia. So that's the difference between these two group of medication. Agonists have no ceiling effect for analgesia, but agonist and agonist have ceiling effect for analgesia. Okay, and examples of agonist and agonist are buprenorphine and pentazocine. So now we will come back to our patient who is on morphine 50 milligram, and you have injection pentazocine and morphine. So what is the action of pentazocine on receptors? It is an agonist at kappa receptor, whereas a weak antagonist at mu. What is morphine? Morphine is a pure mu agonist. So what happens if you give pentazocine to a patient who is already on larger doses of morphine? So here, pentazocine, it is antagonist at mu, whereas morphine is agonist at mu. So pentazocine will replace the morphine from the mu receptor. So what will happen? What will happen?
Won't be effective for pain.
Sorry?
Won't be effective for pain relief.
I couldn't hear you properly, but the morphine
It
is
will not be effective for
Morphine will
pain
not be
relief.
effective for pain.
So pain relief will not be there. That is
Yeah.
what is the response.
Now, instead of you may think, okay, this will give more pain relief, but as the morphine is replaced from the mu receptor, and now pentazocine is sitting on mu receptor and it is acting as an antagonist, so it will produce more pain. Okay, so this is what going to happen, and you have to understand that those opioids which are acting on mu receptors, they are potent opioids. If you look at fentanyl, morphine, methadone, all of them act on mu receptors as agonist. Okay, so in this patient, you should not give injection pentazocine. So essentially what you have to understand is that if a patient is on large dose of mu agonist, never give agonist and agonist group of medication to that patient. So for this patient, you should not give buprenorphine or you should not give pentazocine. And probably you have to take a detailed history. Sometimes he might have missed, she might have missed one dose of morphine in the morning. That might be the reason for increased pain. So be careful when this type of patients comes to you. And now we'll move on to the adverse effects, which we can divide into two. One is side effects and the other is toxic effect. What are the side effects of morphine or opioids in general? I'm talking about
Constipation. Constipation.
Yeah. So what are side effects? Side effects means these are the adverse effects with the therapeutic doses. So the patient has pain relief, but because of the physiological action of opioids, they will have some adverse effects, which are known as side effects. And most importantly, there are a few side effects: constipation, nausea, vomiting, sleepiness and tiredness, itching, dry mouth, and urinary hesitancy. These are the first three are the major side effect or common side effects. And the next three are not very common. So about constipation, it occurs in almost 95% of patients. That means whenever you prescribe opioid to a patient, you have to understand that you are going to produce constipation for that patient. So you have to give a laxative. You have to prescribe a laxative for that patient. It is stimulant laxatives are the drug of choice for opioid-induced constipation. So bisacodyl, sodium pycosulfate, senna. These are the three laxative which comes in stimulant laxatives. So don't forget to prescribe a stimulant laxative whenever you prescribe an opioid. This is very, very important. And this constipation will continue as long as the patient is on opioids. So never stop laxatives when the patient is on opioid. That means tolerance will not develop to constipation. Next is nausea and vomiting, and it occurs in about 1/3 of the patients. But compared to constipation, here the nausea and vomiting that would subside after a few days. So maybe within 3 to 5 days, even if you don't give any antibiotic, the body will get accustomed to it. So only for the first few days, you have to give some antibiotics when you are starting a patient first time on opioids. And it is due to stimulation of chemoreceptor trigger zone in the brain, that is CTZ. And which are the antiemetic preferred? These are the dopaminergic type 2 receptor blockers, D2 blockers. So which are the D2 blockers? Haloperidol and metoclopramide. Either haloperidol or metoclopramide is usually given. Haloperidol, if given, it should be given in very small doses like the 0.5 to 1 milligram. So higher doses are not needed to treat nausea and vomiting due to opioid. Metoclopramide, maybe 10 milligram 8 hourly would be enough. Next is sleepiness and tiredness. And this again occurs almost in 1/3 of the patients on initiation of treatment, or sometimes when you increase the dose, this can happen. But this is also self-limiting. Maybe for the first 2 or 3 days, patient may be a little bit drowsy. That's all. But many of the patients, this may not happen because it occurs in almost 1/3 of the patients only. So next 2/3, there will not be any sleepiness and tiredness. So now I am moving on to toxic effect. So we are talking about adverse effects, which are divided into side effects and then toxic effects. So what are toxic effects? These are the adverse effects when the administered dose is higher than the required dose for pain relief. Okay, and this is manifested by delirium, myoclonic jerks, and drowsiness. Extreme drowsiness. Okay, so myoclonic jerks means these are jerky movements. It may occur in one group of muscle or one muscle or one side of the body or even whole body. So these are sudden jerky movements. Okay, so delirium, it is an acute confusional state, and extreme drowsiness. You may not be able to wake up the patient even if you call. So this is another thing which you brought about when I asked about IV morphine trial, what would be the immediate side effect? So how common the respiratory depression with opioids? So this is a systematic review which says most of the patients takes opioids orally and the dose is gradually increased, which ensures that respiratory depression is unusual. And if respiratory depression occurs, you have to see whether there are any other problems for this patient, like pulmonary embolism, pneumonia, cardiomyopathy, or are you administering a benzodiazepine along with opioids? So these are the other factors which can aggravate this problem. Okay, so what you have to understand is respiratory depression is very, very unusual. I have not seen even a patient with respiratory depression. In the last 20 years of my career in palliative care, I have prescribed maybe 25,000 or more than that or morphine, fentanyl, methadone for many of the patients, not only oral medications, but also injectable preparations. I have not seen. So that means if you know how to administer this medication, the chance of producing respiratory depression is very, very, very minimal. And another thing is that you might have heard about this opioids causing addiction. So the research finding is this: if you use opioids as prescribed, the chance of abuse is very low. And many people have they do not understand the difference between physical dependence and psychological dependence, whereas psychological dependence is known as addiction. So I would just give you an example to understand what is this. Many of you would be taking coffee in the morning. You are taking it for last 20 years, 30 years. And one morning, you do not get coffee. How would your body react? Anybody?
Tiredness.
Sorry?
A tiredness, not fresh.
Lethargic.
Tiredness,
Lethargy.
lethargy. Okay, headache, I can see.
Headache.
Headache. Yeah, anything else? What is it usually you have? Yeah, one is headache. Yawning, isn't it? Yawning.
Yes.
Irritation. So, do you have addiction?
It's a dependence.
How many of you have addiction now?
Yes, it is a dependence. Not addiction.
Okay, so you were unable to make coffee because there were no coffee powder and sugar. But you know that in the neighbor's house, there is coffee powder and sugar, but they have gone out after locking the house. Now you are breaking into their house to get coffee powder and sugar, and then you make coffee, and then you become perfectly okay. If you do that, then you have addiction. That means the psychological depends. But you never do that, isn't it? You will think, okay, I didn't coffee today morning. I am little irritable today, but that's okay. I can overcome that. That is physical dependence. Where body is asking you, you are giving coffee for the last 20 years, then why are you not giving it today? So that is manifested as withdrawal reaction. That is, it is called as withdrawal reaction. So that is the difference between physical dependence and psychological dependence. I am making it very simple just for you to understand. So, but now if you look at psychiatry books, you will not see physical dependence or psychological dependence. They use the word opioid use disorder, OUD. Okay, and how can you diagnose this OUD? According to DSM-5, that is Diagnostic and Statistical Manual 5, there are 11 criteria. I'm not going to read this, but you can go through this once the PowerPoint is available. You can see development of tolerance. And what is development of tolerance? To get the same effect, you need more doses. And withdrawal symptoms that occur after stopping or reducing an opioid. The last two will not be considered for a patient who is on opioid. Okay, because many of the patient, even if they do not have psychological dependence, and if the disease progress, they will have, they need to have more dose of opioid to get the same pain relief. So their tolerance can develop even in patients with who do not have psychological dependence. And if you stop abruptly opioid, that can produce withdrawal reaction. This is not the only medication which can produce withdrawal symptoms when suddenly stop. Why are you tapering and stopping steroids when it is given for a long time? It can produce many problems, isn't it? If you stop suddenly. So essentially what you have to understand is, if you give opioid for more than, this is what is recommended. If you give opioid for more than 1 month, this says you have to taper and stop. Okay. Now, I think I would move on to one prescription. So this is a prescription for a patient, a Mr. X, who has severe pain, and you are starting him on morphine, and you are asked to write a prescription. His serum creatinine is normal. So what all should be there? If you prescribe morphine, what all should be there in the prescription?
So the preparation of morphine,
Yeah.
along with the dose, along
Yeah.
with every half, 4th hourly or 6th hourly, along with the antiemetic.
Yeah. Okay, thank you.
Laxative.
Yeah, according to NDPS Act, that is Narcotic Drug and Psychotropic Substances Act, which governs the stocking and dispensing of essential narcotic drugs in India. They have specified certain things when you prescribe opioids. Essential narcotic drugs, according to NDPS Act, there are 6 essential narcotic drugs in India: morphine, fentanyl, methadone, codeine, hydrocodone, and oxycodone. Out of this, hydrocodone and oxycodone is not available in India, but all the other 4 is available in India. So if you prescribe these essential narcotic drugs, in short form, it is called as END, END, END. Then you need to follow certain rules. So the patient name should be there, age should be there, address, date of prescription, and as Dr. Abdul Hassan told, you should write what is the formulation. Is it a tablet, syrup, or something else? That should be there. Then the name of the END should be in capital letters. And what is the dose of medication you are going to use? It is 10 milligram. And how many days are you prescribing, and how many numbers of END are given? So 10 days, 30 numbers. And then you have to give your signature, name, medical council registration number, and your address. So this is what is required as per Narcotic Drugs and Psychotropic Substances Act. But you also understand that when you prescribe morphine or opioid for the first time, you have to give bisocordyl anyway, that need to be continued, and metoclopramide for the first 3 days. So this is how you have to prescribe. And now I would like to give this, what are the prices of different opioids available to us. Suppose a patient is taking 5 milligram of morphine every 4 hourly. So the total dose would be 30 milligram per day. And if you look at the cost per day, that would only be 3 rupees 50 paise. But if you want to achieve the same pain relief with tramadol, you have to give 300 milligram of tramadol, and that would cost anywhere between 24 to 50 rupees. With the tapentadol also, it's almost same. But with fentanyl patch, you have to give a 12.5 microgram fentanyl patch, which may vary between 250 to 400 rupees. So that means the patient need to spend about 100 times or 100 times more. It is 100 times more costlier than morphine, 250 to 400 rupees. To achieve the same pain relief with buprenorphine patch, it is 1920 per pair. And with methadone, it is almost comparable to morphine. So there would be many medical representatives coming to you, asking you to prescribe fentanyl patch and buprenorphine patch. But nobody would come to you asking to prescribe morphine, isn't it? So you can see the difference, because they do not have any profit out of morphine. But fentanyl and morphine, fentanyl and buprenorphine, it is very costly. So you should be very careful when you prescribe fentanyl patch or buprenorphine to the patient. I think I would stop here and would take a few questions if there are any. Thank you.
A couple of questions were there, like preparation wise, just tablet preparation, strength, what all is there, and then if inhalation route is available. Those were the queries, and there was one more. I will
Preparation, so what?
tablet strength.
Okay. That again depends on the pharmaceuticals who are manufacturing it. But in Kerala, we have 10, 20, and 50 milligram tablets. Previously, 60 milligram was also available. But now it's 10, 20, and 50 immediate release tablets. But a controlled release tablet 10 is available. 10, 20, and 30 is available. And even sometimes 60 is also some people produce. So it all depends on your place and the manufacturer who is making it.
And then another
Regarding
question was,
fentanyl
can
patch,
we?
it is 12.5, 25, 50, and 100 micrograms are available.
And another one was, can we powder the tablet and give it an NG tube?
That can be given if it is an immediate release tablet. Otherwise, if you powder it, the sustained release action will be lost.
And just now a question is there a maximum dose for morphine? And Dr. Aditi's hand is raised. If you can unmute and ask.
Okay, so we have to understand that there is no maximum dose for morphine. The dose which is required for pain relief for the patient is the maximum for that patient. Most of the patients, they would get good pain relief with 5 to 20 milligram of morphine every 4 hours. But I have had a patient who was on 450 milligram of morphine every 4 hours. He was a practicing advocate and he was doing his job after taking 450 milligram of morphine every 4 hours. So, so there is no maximum dose. Yeah, Dr. Aditi.
Dr. Aditi, you can
Sir.
unmute and ask.
Thank you, ma'am. Sir, actually, I wanted to ask about prescription of morphine in patients who are in remission, who have recovered from cancer but have chemotherapy-induced peripheral neuropathies or severe pain, and they are already on buprenorphine patch, antidepressants, and duloxetine, everything. But their pain is still severe. So is prescription of morphine allowed in patients with remission whose cancer has been fully treated, but they have pain lifelong?
Okay, so this is a little bit of, it is a difficult problem. but usually many chemotherapeutic agents, mainly the platins, it can cause severe peripheral neuropathy. And the neuropathic pain agents are usually advised for treating those symptoms, like gabapentin, pregabalin, or as you told, duloxetine, amitriptyline. All those are the medications. But if it becomes so severe that patient's quality of life is compromised, then you might try a trial of opioids, maybe morphine or a methadone. And methadone might have more advantage than morphine in such situation. But if you have only morphine, you can just try to give a morphine, intravenous morphine trial, and see whether the pain is sensitive to opioid. So that is another thing you can understand. If you give intravenous morphine trial, the moment you can understand whether this pain is opioid sensitive. If the pain is opioid sensitive, then you may give opioids, but at the same time, you have to advise the patient regarding the chance of addiction, even though it is very, very less. So ask the patient to take the medication as prescribed and should not be increased without your order. So you should be in a contract with that patient. And he should also understand that this, if you are going to take it long term, that can produce psychological dependence. So
Sir,
that's
are there
how
any
to
legal
manage.
implications? Are there any legal
There
implications?
is no legal implication, but you have to document this in the case sheet or somewhere, and need to get the patient sign also. Because this was the discussion happened. Why did you start morphine? It is because the patient's quality of life was compromised. No other medication were giving proper pain relief. So if you write this properly and document it, then there is no problem.
So do we need to inform the narcotics because there is this cell and there was this rule which stated that you have to inform before starting. In these kind of patients who are not palliative, there was this rule that I came across. So I don't know whether it's still there or not.
No. There is no such rule according to NDPS Act. There is no, they do not specify which patient should receive morphine or other essential narcotic drugs. It is our discretion. But as a general rule, if the patient is having chronic non-cancer pain, then first of all, you have to optimize all the non-pharmacological therapies first. Then you add other medication, and only as a last, you should prescribe opioids. And that also not like patients who are in pain. It is usually said that you should not go beyond 60 to 90 milligram of morphine per day. And you have to review this patient very frequently. And in each visit, you have to find out what are the benefits for this patient with this medication, what are the harms that is causing. And if you see that, okay, this patient is more harm than benefit, then you have to discuss with the patient and stop it.
Yeah, I put a question in the chat box. I don't know whether it comes under the purview of this discussion. Has any doctor been sued for prescribing morphine excessively or inadvertently or something like that?
I have not heard about it, but if you are the person in charge of an RM, recognized medical institution, RMI is the status by which you can stock and dispense essential narcotic drugs. So if there are any problems with counting error or something like that, then there might be problems, legal implications. If you do not maintain the records, then you will have problem. But otherwise, I have not heard of what you have asked.
What
There
all
are a couple more questions, like basically legal implications for what are the rules for RMI or to use or to prescribe, and can these prescriptions be used for friends and relatives if need be? These were the other two questions in the chat box.
So there are, you will have a class on opioid availability where this will be discussed in detail. But for now, RMI is recognized medical institution. Any person, if you have an institution, you can apply for a recognized medical institutions to your corresponding drug controller or who is the supreme authority of your state concerned with drugs. Then now the NDPS rule is same for all the states in India. So you have to apply it in certain format, and the prerequisites are there should be a doctor who has experience in pain and palliative medicine, and there should be enough space for the patient to come and sit down. You should have safe cupboards to lock the morphine, maybe in a double locking cupboard or something like that. So these are the three requirements if you have an institution. But as a registered medical practitioner, they can also apply individually if they want. But the number of medication or number of tablets that you will get with RMP status would be very less. You can keep only 50 numbers of 10 milligram of morphine tablets with you, and you should not be able to sell it. So there are limitations if you take it under RMP status, but if you have a recognized medical institution, then there is no restriction. You can stock and dispense all the ENDs, essential narcotic drugs.
I have two questions.
Yeah.
One, whether anesthesiologist with postgraduate qualification can get license. That is one thing. Another thing, what are the requirements? What are the things we have to document when we are having a license of OPM?
Okay. So anesthetist as such will not be able to get the license, but you should it is not license, it is RMA status. Previously it was license, but now it is called as RMA status. You should have experience in pain and palliative care. If you can show that certificate, then you would be able to apply for that. And according to NDPS Act, there are certain formats that you have to keep in the RMI, recognized medical institution. There are some forms like 3F, all those things, which you will understand in opioid availability class.
That's what there was another question on retaining, should we keep a prescription? I think that also will be answered in the opioid availability class. And one more thing was, is there any specific paper to write the prescription? I don't think that's what it is. There was a question whether is there any specific paper to write the prescription?
No.
Those were the two.
I have showed you a prescription. The name, age, address of the patient should be there. Then I told you you need to specify which formulation are you using. Then the name of the essential narcotic drug in capital letters and the dosage. Along with how many number of days you are giving and how many numbers you are giving. Then you assign your medical, your name, medical council registration number and address. This is what is required as per NDPS Act.
I've checked all the chat box questions. Only thing Dr. Premnath himself asked about the whether any doctor has been sued. Other than that, The rest all I've gone through most of the things from the chat also.
Okay.
I think only thing, no, like as we've had so much discussion about the various cases, we have already gone past the time. So the case discussion was to be done today, can be taken up for the next session. There was a case. I don't think there's a case for the next session. So we have one more session on opioid. This case could be taken up on the next day. Hope that will be okay.
Yeah,
Because it's all
who was supposed to present, please ask the person.
that is what that was my next thing.
It was Dr.
Dr. Sri Sangeet.
Dr. Hamim.
Okay. Is Dr. Hamim still available?
Yes, madam.
Will you be able to present it in the next session, or is that okay
Yes,
for
madam.
you?
Yes, okay, madam. I'll do.
Thank you well. Sangeet, there's no case already submitted for next session, right?
Not yet, ma'am.
So and next session is also pain management. So
yes, ma'am.
We could have this case, and Dr. Hamim also has kindly agreed to do it on the next session. That may be good to do it. So, and as we had plenty of cases today also, and quite an interactive one, so I thought it would have been. Any other queries or questions left, or anybody wants to unmute and ask? Okay. And most of the in detail about morphine, like rules and things, will be dealt, as Dr. Sunil mentioned, in the opioid availability. There's an entire session on it. Who can get, how you can get, what is the procedure, everything will be dealt, and in which these specific things on what are the detail accounting, what prescription, how you write, where you keep, everything will be dealt. Okay. And thank you very much, Dr. Sunil, for an extensive and interactive session. I think most of everyone's queries would have been dealt with. But see, morphine is something, it's still a lot of myth, fear, and things are there. So it is better to know about it well, so that it gives you the confidence to use it appropriately. If it is used appropriately, then the benefit overtakes the risk or the difficulties. Thank you very much, Dr. Sunil Kumar. Anything else you want to add on?
No, thank you.
Big thank you to you, and I'll pass it on to Sangeet.
Thank you, ma'am. Thank you, Dr. Sunil Kumar, for the wonderful presentation. Thank you, Radha ma'am, for facilitating the session wonderfully. Thank you, everyone, for joining the sessions. Thank you all. Let's see you in the next session. Thank you.
Thank you.